Hello, everyone, and thank you for joining us today. My name is Dr. Abhimanyu Sood, and I'm the Chief Scientific Officer at the Chronic Pain Center of Excellence for Canadian Veterans, or CPCOE. It is my pleasure to welcome you to this important webinar, where we will be sharing the results of our recent National Women's Roundtable. At CPCOE, our mission is to advance the understanding, research, and treatment of chronic pain among Canadian veterans and civilians. We work collaboratively with researchers, clinicians, policymakers, and those with lived experience. Central to our approach is ensuring that the evolving needs of diverse veteran populations are reflected in the work we do. Today's discussion reflects a critical and growing area of focus: women's health, specifically the experience of chronic pain among women and women veterans. For too long, women's health, and particularly women's pain, has been under-recognized, under-researched, and quite frankly, underserved. As participation of women in military service continues to grow, so too does our responsibility to understand and address the unique and disproportionate burden of chronic pain they experience. It was this recognition that led us to convene our National Women's Roundtable earlier this year. This roundtable brought together a diverse group of leaders, clinicians, researchers, advocates, and policymakers, and individuals with lived experience. The goal was simple but ambitious: to listen, to learn, and to identify meaningful, actionable priorities that can advance care, research, and policy for women. The work we're sharing today with you is the result of that collective effort, a synthesis of insights intended to inform not just conversation, but real change. These findings will help shape recommendations and policy directions aimed at advancing women's care and research at a national level. This webinar is an opportunity to bring those findings to a broader audience, to you, and to continue building the momentum that began at the roundtable. Over the next hour, my colleagues will walk you through key themes and recommendations emerging from the discussions. We hope the session not only informs your work, but also inspires continued collaboration. Because ultimately, improving outcomes for women, especially women veterans living with chronic pain, is not the responsibility of any one organization. It is a shared responsibility, and one that requires sustained attention, innovation, and partnership. Thank you again for being here and for your commitment to this important work. I will now turn things over to our moderator, Simon Bénard.
Thank you, Dr. Sood. On behalf of the Chronic Pain Center of Excellence for Canadian Veterans, welcome to our Spring 2026 webinar. It is my honor to be your moderator for today's session, which will be divided into two main parts. We will hear first from Dr. Alice Aiken, who will share a recap of the National Roundtable and speak about some of the results of the report. We will then have the pleasure of hearing from Dr. Tanya Di Rena, who will investigate the background of women's pain, research, and identify what needs to be done. There are two streams to choose from, an English language stream et un flux en langue française. We are providing simultaneous translation, and all of the support materials have been translated. The presentations and slides are best viewed in full screen mode. We will take questions after each presentation. I would now like to introduce our first speaker. Dr. Alice Aiken is a professor at Dalhousie University's Faculty of Health and a former vice president, dean, and Royal Canadian Navy veteran. Her work focuses on transforming health systems and advancing evidence-informed policy to improve outcomes for military members, veterans, and their families. She is also a co-founder of the Canadian Institute for Military and Veteran Health Research and has played a national leadership role in shaping Canada's health research priorities. Welcome, Dr. Aiken.
Hello, everybody, and thanks for joining us today. We're very thrilled to be here to talk to you today about women and women veterans, advancing women's health, and a national roundtable we held in April of 2026. As Simon said, I'm Alice Aiken. I am a professor at Dalhousie University and a Canadian Armed Forces veteran. And I was the co-founder of the Canadian Institute for Military and Veteran Health Research, with whom I still conduct research. And of course, with the Chronic Pain Center of Excellence as well, I'm on their scientific advisory board. So the purpose of hosting the roundtable on April 13th was that the Chronic Pain Center of Excellence, that's CPCOE, and the Canadian Pain Society, CPS, wanted to gather researchers, clinicians, policymakers, funders, veterans, people with lived experience, and other national partners together to help shape a coordinated Canadian strategy for research and health systems and policy implementation focused on women and women veterans. The exemplar we used was chronic pain. And the reason this is that approximately 22% of the general population reports chronic pain, but over 50% of Canadian veterans report chronic pain. And it is a gateway to disability. So it is an understudied and critically important variable in healthcare. As we know, women are over half of the Canadian population and are a growing demographic within the Canadian Armed Forces and the veterans community, but they do remain significantly under-researched and underserved. And chronic pain can occur alongside complex physical, psychological, and social comorbidities. And I think when we look at veterans, it's critical that we understand not only treatments for chronic pain, but the causes of chronic pain, and in particular, and for all women, right? Pain is frequently dismissed, it's poorly understood, there lacks coordination, and we need to have trauma-informed and culturally competent health services. I will let you know that I wanted to have some pictures in my slideshow, and I couldn't find, I didn't know if it was fair to use just generic ones. So any pictures you see are going to be of me back in the day when I was serving in the military, and that was me getting my CD, or Canadian Decoration Medal. So when we ran the roundtable, what we found was that some of the gaps that were identified by the participants was that Canada lacks national women-focused data sets, large health data sets. There are some, but they're not well coordinated at all. And they're frequently unusable by researchers because they're so disparate. We lack standardized definitions for many of the conditions that we see. There are very few longitudinal cohort studies, and what this means is a study that would look at a group of women or women veterans over time to see their health trajectory and see how they cope with chronic pain. There are very few women-specific patient outcome measures, which is how the health system determines how you're doing with your chronic pain. Most of these were developed for men. There are very few developed for women. For example, they wouldn't ask about menopause or postpartum. They wouldn't ask about those things. And there are also in Canada very few integrated care pathways for chronic pain. So these challenges are shared by both veterans and civilian women, but they really highlight the need for scalable and inclusive national solutions. So the 5 priority actions were determined by the roundtable. The first was to develop a pan-Canadian women and women veterans chronic pain data strategy with standardized definitions and interoperable data sets. So provincial health data sets, national health data sets, information from Veterans Affairs need to speak, and we need to be able to have a much better understanding of chronic pain. We need to invest in implementation science to translate this research into accessible and high-quality care. We need to support lifespan and gender-specific research that incorporates reproductive health, menopause, trauma, and military service experiences. We need to expand education and awareness for clinicians, policymakers, and the public. And we need to ensure that women and women veterans have representation within national women's health policy frameworks, including Bill S-243, which is a bill about women's health being brought forward by Senator Danielle Henkel. Another photo of my friend and I about to hop on a helicopter for a ride. Oh, that was my, that's my unit in basic training. That was my platoon. So the flagship initiatives that the group came up with, there were three main ones that they felt could fundamentally change the trajectory of chronic pain for women and women veterans. And the first is a pan-Canadian women and women veterans pain data collaborative. So all of the data sets, the national data sets, the provincial health data sets, the Veterans Affairs data sets, the data sets within Statistics Canada, that they all coordinate, and there is a one-stop shop for finding data about women and women veterans, health data. And of course, the data is all anonymized. You would never know who the person was, but there are ways to link the data so we could get a good profile. We also want to coordinate national research priorities. So Senator Henkel's bill has recommended some research priorities about women's health. We had the Standing Committee on Veterans Affairs, who did the Invisible No More report, and they had recommendations around research. And Veterans Affairs themselves did a very in-depth study and coordinated with veterans female veterans right across Canada, and they have a number of research priorities as well. And so it's really critical that all of the relevant groups get together and ensure we're coordinating our national research priorities, that research is not being replicated in several sites, that we know where the research is occurring so that it can be used to inform policies, practices, programming to help women and women veterans with chronic pain. And the final recommendation, because we don't just want research without action, is to develop women and women veterans interdisciplinary pain and wellness hubs. A lot of people with the lived experience of pain told us, they would get some information from their physician, then they'd get some from their physiotherapist, and some from their massage therapist, and some from their psychologist, but that there was no coordination between those care practitioners. And the person within our health system should not be the one who has to figure out how health professionals communicate. We need interdisciplinary hubs to deliver appropriate and timely care to people who suffer from chronic pain. And it's really not just a healthcare issue, it's actually a financial issue as well. If people are getting the right care, they're more likely to show up at work and be productive members of society. So this is a really important and critical recommendation as well. So in conclusion, Canada has a critical opportunity to build a coordinated, trauma-informed, women-centered strategy that improves chronic pain outcomes, reduces disability and workforce loss, and strengthens health equity for women veterans and civilian women alike. And achieving this vision is going to require sustained collaboration, harmonized data systems, interdisciplinary care models, and multi-agency investment across federal, provincial, academic, philanthropic, and industry partners. And while that might sound like a big order, it is not. It is not impossible at all. This can be done, and we need to do it. I look forward to answering any questions you might have.
Thank you very much for this insightful presentation, Dr. Aiken. So we will now transition to questions submitted by our audience. So first question, what are the most practical pathways for women veterans, especially those without a family doctor or living in underserved regions, to access comprehensive chronic pain care today?
Thanks. That's a great question, General Bernard. It's interesting. I think a lot of people have in Canada have the misperception that veterans are cared for by a special health system, and they're not here in Canada. We have great public health, and so when when you release from the military, you release into the provincial health system where you leave the military. So veterans can be without a family doctor like many other people in our health system. And they may choose to live rurally or in an underserved region. So it's a very valid question, is how can veterans access care for chronic pain? I would say, veterans do have some unique pathways. The first and foremost, Veterans Affairs can help. Contacting Veterans Affairs and speaking with someone at Veterans Affairs about your concerns and complaints. I'm not sure they can help get you a family doctor, but they can help access care and supports in your area, wherever you are. So that's good. There's also other support groups through the Legion and many of the charities that would work with veterans that may be able to help in your particular area. And Veterans Ombudsman as well as another organization that I would suggest to try. Now, accessing comprehensive care for chronic pain for any woman in Canada is a challenge. And, our next speaker, Dr. Dorena, is a real pioneer in this area. She started the pain clinic at Women's College, and it is almost the only one in Canada. She's going to give you the exact facts on that. But it is an absolute comprehensive chronic pain center for women and a great model for us to be promoting. So when we did the roundtable, we did not just want for it to be like high level, talking. We wanted action, and I think we've got some great models out there of how pain can be managed appropriately for women and women veterans. Yeah.
And the report is pretty extensive, having a chance to go through it, and there's a lot of opportunities to fix stuff in the coming months and years. So thank you. Thanks for answering that first question. Now, second question from the audience. What concrete system level changes, policy mandates, or care models are needed to ensure women's pain is taken seriously and assessed appropriately across healthcare settings?
So I'm going to start sort of at the ground level, which is, I am a researcher fundamentally in military and veteran health, and there is just not enough health research being done on women. We are not small men. We have unique health needs, and I was doing a little bit of research and found out that the gender-based analysis plus rules for publicly funded health research in Canada were adopted in 1995. 1995. And we still do not have enough research with women in it. Clinical trials focused on women, all kinds of health research. And there's been global sex and gender equity and research guidelines. They're called SAGR guidelines. It's an acronym. And they were introduced in 2016 in Europe and globally. And Canada has signed onto all of these. And yet There's still always excuses why research is not being done on women. So until we actually know about women's health care, I'm not sure how clinicians are meant to implement appropriate care when there is a very, very large lack of evidence. So my plea is to my research colleagues and research funders to not allow people to make an excuse for not including women in their studies. They must. They just must.
Absolutely. And part of the report also, it was raised the even standardized definitions, and national data sets, as you mentioned, and cohort studies following women through service and post-service life are not there to provide
No,
that data and evidence-based research that will lead to better policies and so forth. Yeah,
absolutely. I'll give you a great example, Simon. Menopause affects 50% of the population. And we know almost nothing about it. And one of the first publicly funded menopause focused clinics is opening this year here in Halifax. It's
really,
been affecting women since forever, right?
2026.
So, yeah. Hmm.
Never too late, I guess, but still
Yeah.
a lot of work to do and to go. Okay, I have a third question here from the audience. How can healthcare providers be better trained to recognize and respond to women's pain, particularly complex or overlapping conditions like chronic pain and PTSD, for example?
Yeah, I will say that I'm particularly proud of some of the work that's happened in Canada looking at the role of post-traumatic stress and chronic pain, the overlap between them, and that it can exacerbate post-traumatic stress can exacerbate a condition like chronic pain. But again, to go back to the basics, it's not really taught in health professional or medical schools. So I think people, if they're lucky enough to have a clinical placement on a base with the military, or to have that understanding, that they might have a bit of a clue about it, but it's really not taught in health professional schools. And we need to change that. When we founded the Canadian Institute for Military and Veteran Health Research, I was a professor at Queen's at the time. And at that time, the dean of the Faculty of Health Sciences, who was a physician, and the dean of medicine, he implemented a veterans health course for all medical students at Queen's. So I don't know if that continues today. Maybe somebody online has a better sense of that. But we really need for there to be a will to teach people about health, about the unique needs of service. And it's not just the military personnel and veterans, it's their families as well. And I will tell you, Dr. Sood and I are leading a charge to get military identifier, veterans identifier, or family identifier added into all publicly funded health research in Canada. So right now, this is a dream for me, and I'm telling you all this. So any way you can help us, please do.
And veterans have to identify. Some of them don't when they leave the
Yeah.
military. They don't
Well,
want to
and you're
be
not
recognized.
asked, right? I have never once been asked if I'm a veteran.
No, you're right. I've just been retired since August, and very few have actually asked the question. I had to basically come forward and tell my situation.
And to be
Okay,
honest, Simon, they're going to ask someone who looks like you a lot sooner than they're going to ask someone who looks like me, right?
yeah, that's and again, reading the report, I'm like, really, 2026, this is where we're at, and I
Mhm.
don't want to steal Dr. D. Rena's thunder. I know this is going to be a subject, but yeah, 2026. I mean, we should be in a better position right now. We have time
Indeed.
for another question, if I may. Um, what are the most impactful actions healthcare providers and organizations can take right now to improve pain care for women veterans, including opportunities for partnerships or pilot programs?
So there's a few things. I think, first of all, care providers can ask if somebody is a veteran, and there's a decent database of veterans health research out there now, that people could look up. That's publicly available, open access. So I think asking is a start. But you know, part of what came out loud and clear from the roundtable, and there is good support across organizations, is we do need a national research agenda from all of the different sources that have already contributed. We need to get the data sorted out. This is an imperative. And we need to start thinking about how to replicate multidisciplinary pain clinics, such as the one Dr. Durena runs. So I think those are all critically important. And I would ask, you know, everybody who is joining us here today is obviously interested in this subject, and you have your own spheres of influence. Please help us and join us. This is a critical movement that we need to move forward.
Really good. Thank you. Yes, we need a mobilization plan in this aspect. So thank you to our listeners for your questions. Dr. Aiken's presentation really set the scene well for Dr. Direna, our next speaker. Dr. Tanya Direna is an associate professor at the University of Toronto in anesthesiology and pain medicine and medical director of the Toronto Academic Pain Medicine Institute. A specialist in chronic pain, she practices at Women's College Hospital and has held key leadership roles in provincial, national, and international pain organizations, including serving as president of the Canadian Pain Society. Welcome, Dr. Direna.
All right. Hi, everybody. I'm Dr. Tanya Direna. I'm the president of the Canadian Pain Society. I am also a pain physician at Women's College Hospital and UHN and an anesthesiologist. And I'm an associate professor at the University of Toronto. And there are my objectives today. I always think of the next generation of girls, my girls, and women. So this is who we're doing it for. These are the more formal objectives. I'm not going to read through them, but we are going to talk about chronic pain in women and chronic pain in our female veterans. And we'll highlight what's happening in Canada. So I am the medical director of a partnership called TAPME, which is a central hub in the Greater Toronto Area. We have 5 academic hospitals within our institution. And I'm a female physician, and I call this my female physician face, as I oscillate through various emotions of anger and frustration as I get older. And it's not menopause, and my Botox wears off really quickly. But my life as a female physician is getting more and more frustrating, mainly because I realize there's a significant pay gap between my male colleagues and I. I'm less likely to get a promotion, as women are consistently across medicine. We're more likely to be interrupted by both our female and male colleagues. And we are more likely to be called by our first names by patients than our male colleagues. And so it's a bit frustrating. And it's also, you know, very frustrating that I do a practice that really demands long visits and attention and trauma-informed approaches, and it's really not compensated well. So women's health, I think, is not compensated well because our system really values procedures, volume, and speed. And we don't need that. We need people to listen to us. And so even when you look at female bodies, so embryologically, ovaries and testicles are very similar, and yet, you know, the removal of them is paid significantly more if you're removing testicles than removing ovaries. So I just find it funny that even our female bodies are reimbursed less by the medical system. And so I feel like women's health is less valued. And the more I think about this, you know, it makes me sad. In fact, here's the twist. We actually deliver, as female physicians, lower patient mortality rates, fewer complications, and higher adherence to clinical guidelines. We actually perform better than our male colleagues. And so I try not to pity myself too much, because then I think about women in the military and what does it feel like for a woman who's worn a uniform and now comes home not wearing a uniform. They don't have the institutional power that I have. And so I think about, you know, how their life is. And so this is why this topic is so important to me. When I look at chronic pain in women veterans, the pain prevalence is significantly higher, 51% in female veterans versus 22% in the general population. And this is thanks to the Atlas team for giving me this information. This was a survey of 207 female veterans. And they found that pain limits most of people's activities, and over 2/3 of the participants are currently experiencing chronic pain. That is severe, 17%. It's severe. And so this is a significant issue. And a lot of us find that pain is minimized or not even linked to service in our women veterans. And so this is an issue. And there was an entire report, the Invisible No More report, looking at the experiences of Canadian women veterans, and it really highlighted the overlooked needs of Canadian women veterans. And there was 42 recommendations that I hope will someday come to fruition and be acted on by our Veterans Affairs. And so, women veterans is not very different from women in the general population. There's always a gender bias in pain care for women. We'll wait longer for pain medication in the emergency room. We'll be labeled more emotional, or our pain is psychological or exaggerated. We're given less aggressive treatment. Like if a man complains about pain, they're treated very aggressively. And it takes us a very long time to be diagnosed. And so this is found, in our veteran chronic pain research, and you'll hear the CPCOE folks, Abby, talk about this. There's a lack of sex and gender reporting in the military. And just like us in the medical field, women in the medical field perform very well, and women are really essential to military success. Female teams or mixed gender units have better unit cohesion. There's superior intelligence gathering because we have access to half the population that maybe males in the military wouldn't have. And so we are essential in all streams. And we have pain, and it's, usually dismissed or misunderstood because we follow a very male model in medicine. Chronic pain is a big deal in Canada. For Canadian women, it's 1 in 5 Canadian women. We're more likely to be affected by it. And 70% of my patients that walk through the door are women who have chronic pain. And it's worse in marginalized groups, right? The highest burden is seen in older women and marginalized communities, people of color, Indigenous women, the LGBTQ+ community, significantly affected by chronic pain. So this is important for us. And so history matters. We were excluded from a lot of the research from 1977 to the mid to late 90s. And so we missed decades of research that was important in chronic pain. And so the default prototype is males. And so you can even look at your Tylenol pill bottle. I mean, it's male-centric dosing. They just give kilograms. And there is a significant difference in sex differences in how we process medications. We have more side effects. Estrogen is a protein binder, and so drugs will stick around for a lot longer. And so we'll have more side effects, and the drugs won't work for us. And so what happens is we'll go back to the physician more often, and we're seen as being more complicated, and we get dismissed every time. And we're still behind, even though we started getting studied more and more in the 90s. There's, only 7% of health funding focuses on women's health. It's less than 10%. And we're still leaving people out, right? When you look at our non-binary folks, we're not even capturing these folks. We don't even know how to manage non-binary folks. And there's tons of medical trauma there. And if we don't count them, it doesn't mean their pain goes away or they're cured. It means that we're not really caring for them. And non-binary and gender diverse people are more likely to serve in the military. If you look at Gen Z Canadians, I mean, it's 1 in 10. The next generation, they're going to more and more are going to be gender diverse. It's the most gender diverse generation in history. So it behooves us to learn more about non-binary and gender diverse care in the healthcare system. And so this is important, and it has a cost. I mean, this is a workforce issue. It's a productivity issue. If we spend more time in poor health during our working years, it's going to impact our GDP, right? And so I always think about the $37 billion opportunity that McKinsey talks about, and I'll women's-plain this, but if you help out women in Canada, you will reduce disability, increase productivity, and lower our healthcare costs. So this is great for our economic gain. And if you think about the military, I mean, this is great for retention, right? Most recruitment happens at the dinner table. And if mom is in pain, no one's joining the military. And so it's not about money, it's about basic dignity and function, but yeah, it's dollars and cents, right? And Canada does have a great national pain strategy. It was created in 2021. And we had 150 plus recommendations that we're slowly working on. And the things we really need to do is do the research, right? We have to have sex and gender analysis. We have to create the clinical care specifically for women and gender diverse folks. We have a different reproductive life cycle with different diseases that affect that reproductive life cycle. And we have to have good policy to allocate resources proportional to burden on women, not legacy bias. There are some great frameworks that come up with recommendations about sex and gender. And these were put out this last year by the Pain Diff Network. And these are the conditions that are going to really affect our lifespan and our health span. And so if you look under the health span conditions or diseases that affect the quality of healthy years, they are endometriosis, menopause, migraine, and premenstrual syndrome. All of these kind of have their own chronic pain issues associated with them. And when you look at frequent chronic pain conditions common in women, it's very similar. Migraine headaches, back and neck pain, usually associated with service-related injuries or strain, pelvic pain, arthritis, and fibromyalgia. And we're very lucky in Canada. Unlike south of the border, we are investing in women's health research initiatives. There's a National Women's Health Research Initiative that you see here with about over $13 million in funding. And those are the conditions that are being funded. We are lucky enough in my group to be studying endometriosis, and we're trying to diagnose it very early because 11 years is way too long to wait. And by the time I see them, they have fulminant chronic pain conditions. And so I'm lucky enough to work in an interdisciplinary pelvic pain program with health disciplines that are really skilled. This is the gold standard to have interdisciplinary pain care with a unified approach. The studies tell us that it decreases pain severity, it decreases depression, it increases function and self-efficacy. And really the future of pain for women and non-binary folks is, who really look at us across our entire reproductive lifespan, look at us from a mental health aspect, a physical health aspect, across our reproductive lifespan that has those conditions associated with it. And so, we can take a look at other parts of the globe that are doing female veteran integration very well. And Helen Lesseler kind of pointed this out to us in an email about a resource from the UK where there's a female veterans transformation program. And I really ask you to take a look through it because it's quite good. It looks, it gives folks a toolkit on how to address physical and mental health issues in female populations. It even has a great piece on the non-binary folks. And so it's really important for us to learn from other countries who have female veterans. This is not a female veteran directed initiative, but it's a really great initiative in Spain. And they're lucky to really be forward thinking in terms of female health. They actually have a menstrual health policy that allows 3 days off if patients are diagnosed with dysmenorrhea. When you think of dysmenorrhea, painful periods, anything happening in the reproductive cycle, you have to think about productivity. I mean, women lose their jobs because of pain that's affiliated with your menstrual cycle or the reproductive cycle. And then we're no longer productive. And then we fall into poverty. And then we utilize the healthcare system more. So I think these initiatives, these policies are really great to keep us healthy. And, it all boils down to dollars and cents, but keeping more money in the system. And so I really want to thank you all for listening to my spiel. I really want us to, stop asking us to advocate harder. I think we need to build systems that really listen to women and no longer follow a male default model. So thank you so much. And I look forward to hearing all of your questions about what's occurring in Canada from a research perspective. Thank you.
Thank you, Dr. Direna, for that incredible presentation. A lot of things resonated. What you mentioned about female engagement teams, saw them in action in Afghanistan. Again, access to that whole silent population really was actually a really good advantage operationally on the ground to have women engagement teams. And something else, you talked about that resonated with me. Senior leaders in the CAF always think of operational readiness, and everything we can do to fix this is going to bring basically the force to an operational readiness level that we aspire to have. So we'll go with questions from the audience. First question, why is women's pain still often minimized or dismissed in clinical practice? And what can be done both by providers and patients to counter this bias?
Thank you, General Bernard. This is a great question, and I think I kind of touched on it during the presentation. I think a lot of it is just a lack of understanding. And it's not all physicians. This is not the general medical community, especially as more and more women are a part of STEM, like, science, technology, engineering, medicine. The dial is moving forward. So we're starting to understand a bit more, but we're still behind in how disease processes present in women. And so I think a lot of that minimization and dismissal boils down to a little bit of ignorance about kind of what conditions we have and what causes us pain. I think we don't really understand as much in the general medical population about the hormonal influence. I mean, it is not hormonal, but there's definitely a hormonal influence in both males and females. When you look at studies in kids, boys and girls have the same number of migraine headaches in terms of incidence. And then once puberty hits, the estrogen causes migraine headaches to increase. And the boys basically plateau or decline because testosterone is protective. So this hormonal influence is important. And it's also this kind of social model in how we're raised. We're raised to be helpless. We're raised to ask for help. We're raised that we're not good enough. Being a girl is an insult. Running like a girl is an insult. Last time I checked, Simone Biles was one of the best athletes in the world, and yet it's still an insult. So I think a lot of it is a lack of understanding.
Thank you. Thank you for that comprehensive answer. I'll go to the second question here. What is one practical step a woman living with chronic pain can take today to better advocate for herself within the healthcare system or systems?
That's a great question. I really do want to direct a lot of people with chronic pain, if you're in the audience, to a great website called the poweroverpainportal.ca. And it is a pan-Canadian effort to give people evidence-based and evidence-informed information about chronic pain. So you can enter that portal whether you're an adult or a youth. It's in French and it's in English, and you can learn about pain. So become educated about what chronic pain is, because it's different than acute pain. So the definition of chronic pain is pain that lasts longer than 3 months. And so the way I would describe it in some conditions is, if you don't have active disease, it is not a symptom of an acute problem. It is actually the disease of feeling pain. And so it is, if you have a fire and the fire alarm bell goes off, the fire alarm bell is broken. And so that's the disease of chronic pain. And so I think it's important to get that understanding, because people come in thinking they still have a fire and no one's figured it out. And so I think highlighting your goals and telling physicians or health disciplines how this ongoing broken fire alarm bell has disrupted your life is really important. And list your goals kind of at the beginning, because sometimes we are time-based mostly. And if you wait to the end, we may not kind of understand the full breadth of what your needs are. But I think the first step is some psychoeducation, some education from a good quality source. Please, stay away from people trying to sell you stuff. Stay away from some of the snake oil. This is not going to work. Chronic pain requires an interdisciplinary, it requires every aspect of your life to be addressed, from sleep, from mood, relationships, even communication is important, pacing yourself, informing your work, how this is making you feel and how they could help you better stay employed. These are all important skills. And I think that portal is going to be the first stepping stone in finding how to help yourself if you've got a chronic pain disorder.
So really good tip with Power Over Pain portal. So I'll go and have a look at it after this webinar. But I also reflect on, our culture. There's a cultural aspect to this with the forces, right? Like I joined in the late 80s, in 88 actually. So, and at that time it was like no pain, no gain, right? We were actually working hard, pushing our limits, not getting a lot of sleep over infantry training and so forth. So there's a leadership responsibility here to basically talk about pain and have soldiers, sailors, aviators, and special operators be open to having a discussion, even with their leadership, let alone the clinicians, right?
That is a beautiful thing to say. Honestly, communication is key, and the leaders have to have these open conversations about how they can make people succeed. Right? If somebody has a chronic pain condition, and somebody will on this panel, it's 1 in 5 of us. So somebody will. So ensuring that people can succeed and communicate how they can be better supported is an ideal situation. And you're right, it starts from the top. Well said.
And 1 out of 2 of our sisters in arms. Like when I saw that statistic, I was like, oh my God, like I've been failing for 30 years, not even knowing that. But anyway, here we are with, best practices and opportunities to fix stuff. I'll go with the third question here. How can clinicians more effectively assess and understand pain beyond that traditional 1 to 10 scale, right?
Yeah. Yeah, and it's different in chronic pain, right? Because you have to understand how it really disrupts your life, your ability to work and function in your family. I always say, that broken fire alarm bell, you've stopped cooking and everyone in your house is going hungry. And so that's the big issue, right? Sometimes it's not to figure out what caused the fire a couple of years ago. It might be very difficult to figure out what the primary generator was. But the biggest deal now is that you've stopped cooking and all of your family is going hungry. And so this is what we work on, and this is what we have to figure out. Like, how is your mood? How is your sleep? How are your relationships? I do pelvic pain, so sexual health is a big measure to me. Some people don't want to be touched anymore, and it's affected their relationships, and they've separated. And these are important things to ask because it's important to let people know how chronic pain can affect your life.
Yeah, and to be honest, I retired last August and I had never heard of chronic pain per se. And thinking that chronic pain will be something that you endure for 3 months and over, I can tell you that throughout my career, I had chronic pain at various steps in my career progression. You mentioned trauma-informed care. Could you explain what that is and why it is important for women veterans and civilian women with chronic pain?
Yeah, I'm so glad you asked that. I think there's a huge part about educating our health disciplines and our healthcare practitioners also about cultural competency when dealing with veterans. There's a significant amount of trauma in this population, and learning how to manage people who've had such significant amount of trauma, learning to understand that they may not feel safe with a male in the room examining them, learning to ask for chaperones, asking permission to ask questions, asking for support, and dividing up meetings into several visits. Like I said, it's a model where we're paid to do things rapidly and fast, and that can be so triggering. And then we push you out of our clinic, and there you are, being left to deal with such significant trauma that affected your life so significantly. So having this real approach where people are a partner in the care is extremely important. And having those competencies taught in medical school or at any health discipline professional school is extremely important.
And that interdisciplinary approach that you mentioned is so critical. Otherwise, you're going to one office. The 2 days after, you're going to see someone else. They don't talk to each other, so it's very dislocated. And again, the burden shouldn't be on our veterans to have to look for these services and that care. So, what evidence-based or emerging approaches, and I think we started talking about that, but there's, for example, somatic therapies, social support, alternative treatments show the most promise from improving quality of life for women with chronic pain.
Yeah, it's almost like we fixed that, right? General, it's almost like that was a setup to the next question, which came so perfectly. That interdisciplinary model is the gold standard for people, and we should be able to offer it, at least for our veterans after they've served for our country and help keep us protected. So I think that is the gold standard, having each aspect of your life addressed in terms of your mobility, having like physiotherapy, having parts of psychotherapy, like psychological trauma-informed practices. We do a lot of psychological therapies at our program, which is called TAPME, that people are allowed to register for. They don't need a physician to enter these group therapies. And we teach people a lot about regulating your nervous system, about, and having compassion. We lose compassion. I can see that, especially for a veteran population, just like you said so eloquently, General, you are taught to not complain. And then when it's time to complain, you don't know how to do it and you hate yourself for it. And so these aspects of self-compassion are really important. So that interdisciplinary care with a physiotherapist, with a psychologist, with an occupational therapist or social workers, that is going to be the key. It's not just one needle. It's not just one pill. There's no panacea. It's all of it. All of that has to be done in order to help people manage.
And ideally, all of these experts are all in the same location, right? So that veteran doesn't have to drive, 3 hours to go to Saint Anne and then back to Quebec City, and 2 weeks after he has another appointment. It dislocates the whole approach.
I want to add one more aspect about,
Yes.
on top of that, add in the layer of being a female, add in the layer of having endometriosis and a monthly menstrual cycle that prevents you from getting out of bed. Add in pregnancy, add in postpartum depression, add in postpartum pain or post-pregnancy pain, add in menopause and the effects of menopause on your mental health, your cognitive function, and pain conditions that's around menopause. Like, add in that whole reproductive cycle on top of what we know about chronic pain in itself. It's a different animal for us. And then, add in the non-binary people and the trans people where we're not even asking the questions. So these are all things we have to be doing, like Dr. Aiken mentioned. There is a series, 6 points that we put forward. I'm really excited about this report, and I'm really excited about what we're going to do.
Really good. And I would recommend our audience to go and read the report and see, what the plan is going forward, because I think it's all good to recognize the current situation we're in, but even more important to develop a plan for the future and to fix this. The timelines that have been determined for the implementation of the goals that were mentioned in the report, what sort of horizon are we looking at? Do you have that handy, or?
So I'll hop
Oh.
in there. We've already started to implement some of them. We're already working on the data strategy with Stats Canada, Veterans Affairs, really trying to move the agenda forward, and the Canadian Institutes of Health Research. So we are starting down that road already, and we're now bringing in others who can help us achieve the goal as well. The Chronic Pain Center of Excellence, Dr. Ramesh Zacharias and Dr. Abhimanyu Sood and the team do not want this to be a report sitting on a shelf. They want it to move. They want it to make a difference. And we know that our colleagues across all of the organizations want to see this move as well. And so we've already started.
Really good. Well done. And, I just saw you jumped in, Dr. Aiken, just like, if our team partner would, under a different, unexpected question, and you had the answer. Thank you for jumping in and answering that question.
Not bad for a Navy girl, right?
And thank you for your service, by the way. So we probably have time for one final question, and I'll address this to both of you. How do women veterans and civilians become involved in research to help themselves and other women living with chronic pain? How do they access research? How do they contribute to the effort? Maybe I'll start with you, Dr. Egan.
Sure. Well, the Chronic Pain Center of Excellence has a veterans group where they actually will link veterans who are interested with research that's being done on chronic pain. So I would suggest that's a great place to start. I know Atlas Institute has something similar, and so does the Canadian Institute for Military and Veteran Health Research, or CIMVR. So I would say starting with the institutes that are focused on the population is a great place to start. Dr. Dorena might have some suggestions about civilian women.
Yeah, thank you. We do a lot of education initiatives through the Canadian Pain Society. Every last Friday of the month is National Pain Rounds. You can also, if you're interested in joining civilian projects, there's a list of research that's happening for chronic pain on the painconnect.ca website, and you can join either as an advisor or as a participant in research. You can join philanthropically if you ever possible. There's a lot of institutions that are looking to support this. Even a small donation always helps. It can't always be government that supports this completely. We have to get small businesses and businesses involved in supporting us if you think this is important. So we're always looking at philanthropy to help us out as well.
Really good. Thank you. So just the key takeaways from the report and from this webinar that I actually gathered is, number one, evidence and data gaps, fundamental, right? If we're going to do this right. Clinical and systemic inequities as we speak. Women's pain being frequently dismissed or minimized, as you mentioned, Dr. Direna. Policy barriers. Again, women veterans don't always self-identify, limiting access to benefits. We need gender-neutral policies because right now all policies default to male baselines. Lack of coordinated federal and provincial frameworks, and post-service income decline is more severe for women veterans. That was mentioned in the report. So the strategic priorities, and you sort of alluded to that, making it visible, making it credible, coordinated, and actionable, I think is key to all of this. And the flagship initiatives that were mentioned by Dr. Aiken, this Pan-Canadian Women and Women Veterans Pain Data Collaborative, a national research agenda, and as you just mentioned, partnerships, funding and partnership pathways to enter into this national research agenda. So I'd like to thank both of our speakers today for their presentations and for answering those questions. Thank you very much for taking the time. The Chronic Pain Center of Excellence for Canadian Veterans aims to bring hope to all veterans living with chronic pain and their families. I remind you that a recording of this and all of our sessions will be available on our website, and any question you might have can also be asked through our site at the email address listed. And the questions that we haven't had a chance to answer during the webinar will be answered in the coming weeks. Dr. Zacharias had mentioned that all questions will be answered. Just give the team a little bit of time, to answer them correctly and be able to forward it to the subject matter experts. But we will endeavor to answer all of your questions. Please do not hesitate to contact us for any information you may require. We would also be happy to get your feedback on these sessions. Do you find them useful from a veteran's perspective or from a clinician's perspective? And if you have any comments on or topics you'd like to hear about, let us know. There are the webinars, but there's also the Most Painful podcast, ou le balado le plus douloureux, that the CPCOE runs. And this event today basically concludes our Spring 2026 webinar series. We hope you will be with us for more education, and please subscribe to our mailing list to keep up to date. On behalf of the Chronic Pain Center of Excellence for Canadian Veterans, thank you et à la prochaine.